Good evening. Today we have Dr. Mukesh Hariawala, one of the eminent cardiothoracic surgeon. He was trained in India and then he moved on to UK, from there to US. Now he is one of the leading cardiothoracic surgeon in US and is doing his surgery in Harvard University. He's not only a cardiothoracic surgeon but is also a health economist who have an MBA in health economics. He has a larger interest of not only in cardiothoracic surgery, but his interest is also in angiogenesis. He is now considered as one of the pioneer in what we call as angiogenesis in cardiac treatment. Today we are happy to welcome him to this World Congress of Cardiology. And good evening, Dr. Mukesh Hariawala.
Good evening, Dr. Ramasamy. Thank you very much for having me on the show. I'm delighted to be at this Congress and meet so many healthcare leaders in cardiology and within the industry at this conference in Mount Abu. So thank you for having me on the show.
It's great. I mean, you are today here in India. So what is your initial impression on the healthcare sector in India? And as an expert, how do you view the Indian healthcare industry?
Yeah, I think healthcare sector and industry as a whole does need refinement. But the fact still remains that Indian doctors are one of the best in the world. Indian surgeons within India whose results are as comparable to those in any part of the Western world. The cardiologists in India are also one of the finest. But the Indian population, and by population I mean the Indian cardiac population, does need some amount of advanced education. Advanced education is for patients who need to understand what are the new evolving therapies available for an Indian patient with heart disease. In the Western world, this is all very clearly identified, but it is not yet in the Indian world. So I think education is going to play a significant role in bringing all the newer therapies for these patients, which are extremely efficient and documented that it works and provides symptomatic and disease relief to patients.
Great. As a cardiothoracic surgeon, you might have operated thousands of patients. Now, as a pioneer in angiogenesis, what is your take on evolving new treatment? Do you think any of these evolving new treatment have like a great impact in the upcoming cardiac patients?
And the potential for it to, and the potential, I think any kind of new treatment that is documented in the Western world by FDA clinical trials or having a CE approval in Europe, that is a great opportunity for India, because every new therapy, and let me give you the example of one of the therapies that I am very fond of talking positively about, because it incorporates a science that I have had an opportunity at Harvard in Boston to do some early investigational and research work, and that is a science called angiogenesis. Angiogenesis, and it is one of the lectures that I'm supposed to give at this World Congress here in Mount Abu. Angiogenesis is a very advanced science which is not still very clearly understood in India. It is a science whereby it is proliferation of new blood vessels on the heart from existing blood vessels. So to extrapolate that information in a disease state of a heart patient is that when a person has coronary artery disease, they are offered initial options of, say, angiography, angioplasty, subsequently stent. Currently, all over the world, bypass surgery is deferred for a future date. Bypass surgery in the past, when I did my training, was the first option. Now bypass surgery is given as the last option. The reason is because there are other therapies that are out there, and one of the very promising therapy is ECP followed by shockwave therapy. Both of them utilize the principles of angiogenesis. The principles of angiogenesis is stimulation of growth of blood vessels using ECP technology or shockwave therapy to provide micro level collateral circulation to an ischemic myocardium. An ischemic myocardium for the common man is where blood supply cannot reach. If blood supply does not reach a certain territory of the heart, which means there is inadequate oxygenation. Inadequate oxygenation gives rise to breathlessness, chest pain, deprivement of quality of life. So there are several implications, but fortunately there are promising therapies, as I mentioned, like ECP, that can circumvent that for patients who are not candidates for bypass surgery or angioplasty or stents, especially diabetics, hypertensives, and those who have diffuse disease. Diffuse disease are patients who cannot accept a stent because of the size of the artery. I as a surgeon cannot put a bypass graft because the recipient vessel is very small. ECP technology is a technology that addresses small vessels and not the big vessels. There is a very large opportunity to treat Indian patients who are suffering from microvessel disease, and ECP is well documented as a standard option in the Western world for patients who fall into that class of category.
So thank you, Doctor. And then you talk about this new evolving therapy. Could you be able to elaborate something about this new treatment into the Indian scenario, how effective it could be to the Indian population? Because there are a lot of data coming and showing Indian population can be completely different from the European or a US. Yes. So how relevant is new technology to the Indian population?
Well, more than the relevance of the technology, you need to understand is coronary artery disease in an Indian patient is different than coronary artery disease in an American or a European patient. And the basic difference is there is a very high preponderance of genetic predisposition to disease. So genetically, Indians are more prone to heart disease to begin with. The other thing is that the Indian heart disease, the vessels are smaller than the Western population. It is easier to do surgery on an European or an American patient than to do surgery on an Indian patient.
Yes, doctor. Can you elaborate about this new non-invasive treatment which you are mentioning about? Yeah.
Yes. As I mentioned, there is a very bright future for non-invasive treatment in India. The bright future in the sense is treating a larger population at an great economic advantage when you are treating patients like that. For example, a good portion of India cannot really afford bypass surgery. Coronary artery disease is so prevalent in rural India and everywhere that it is not affordable. So one should always look at the positive side of things is what can we offer such patients, and that is where the non-invasive part, provided they correctly qualify for a non-invasive ECP and other therapies should not be viewed as an alternative to bypass surgery and stent, but there are selective group of patients who stand to benefit the most. If ECP is offered correctly to these pre-identified patients, I believe ECP will get itself well established just like the United States. Even in India, the acceptability rate will be higher. There will be support from government agencies. More insurance companies will be happy to incorporate ECP as part of their portfolio of offering therapies to patients.
That's great. And also I would like to know, you have mentioned about this non-invasive treatment, and I've been privileged to attend your lecture on this health economics. I want to ask you, what would be the relevance of this non-invasive treatment in an Indian scenario? Because you know, India is a very large country where almost 20 million people has cardiovascular disease. So how would this non-invasive treatment can be positioned as a cost-effective modality for the patients?
If one does the math or run the algorithms of cost compared to value proposition that you offer to a certain group of population, is that a non-invasive therapy, if it provides that symptomatic relief, it provides symptomatic relief to a very large population in India, I think the eventual burden on the exchequer of India and the government of India will decline. And that is where I think ECP has a significant role. So ECP is doing two things. It is providing relief to patients, but it is also giving an impact and reducing the economic burden on India for healthcare. So it is a twin approach that you are serving society. So because those resources that are spent heavily on healthcare, that will decline and can be used much more for maybe rural development and other purposes, because you are addressing a healthcare need, applying principles of economicity.
Yes. Fine. I mean, do you think this new treatment would have some effect on the existing treatment, or you think it is only suitable for a group which cannot go for this standard mode of treatment?
No, I think it has great value in, and probably with an expansion of indications of non-invasive therapies, it could work very well in synergy with existing therapies. For example, you can apply a combination therapy in patients where you can do 2 grafts, but a third portion is non-graftable. You can apply ECP therapy that it begins some angiogenic stimulation and perfusion to territories which were non-bypassable. So one can say it is a bypass to bypass surgery for that specific zone that was under revascularized by conventional therapy. The other thing is that following bypass surgery and stents, as patients continue to live longer, the average lifespan of an Indian is now increasing. But with increasing age, there is also going to be native progression of disease. In that native progression of disease, there will be some group of patients who will qualify as redo bypass surgery patients. Redo bypass surgery patients, as you know, is a very high morbid procedure, a higher mortality than first time procedure. There will be many patients who may make a social, if not a scientific kind of decision that they would prefer ECP. That very much can be encouraged. It is, at least there is some offering as opposed to none. There will be some patients who will have no bypassable territories. ECP can be offered again to those patients. So again, even in a second tier of offering therapeutic option to a patient, ECP has a role. Thus, if you look at the whole map within India, the footprint of ECP has to increase. There will be augmentation, but a significant role for augmentation of the ECP footprint in India is going to be directly proportional to the education of the Indian population, education of the cardiac surgeon and the cardiologist. It is a combination of this spectrum that will take ECP to the next level, and I am talking specifically about service to our population. That service, there is an opportunity for ECP technology to provide that service to our population.
Another question, doctor, regarding because of the success in intervention, we definitely know the survival of the patient has increased significantly in India.
The longevity.
Longevity. And there are a lot of questions now arising but what we call as a heart failure. So what is this heart failure? What is it about heart failure, and how do you think that India should tackle this heart failure population?
Yes, heart failure in terms of most Western worlds, now patients who may get optimum therapy. In heart failure, optimizing an option to the patient is going to be the key. There will be patients who are best candidates for bypass surgery. There will be patients who are best candidates for stent. But there will be patients who are best candidates for ECP. Heart failure class 4, which is the final class where a patient gets bedridden and the only option offered to that unfortunate patient is a heart transplant. Unfortunately, although the surgeons in India are very well qualified and trained to perform heart transplant, but it is still not reached a point where it can become an offering to every hospital, simply because of the very high cost of heart transplantation. Traffic issues in heart transplantation. There are only 5.5 hours available from a vehicular accident to delivery of a heart, which is called the ischemic period of transplantation. If you deliver a heart more than 5.5 hours, the operation is a failure before even you start the operation. So those are the technical modalities of transplant. One of the other technologies that I am the brand ambassador to India is an mechanical artificial heart. A mechanical artificial heart is a device that overrides the failing function of the left ventricle and it takes over that role. And it bypasses the left ventricle and it pumps blood to the rest of the bodies, and now patient can have a good quality of life and things. But there is a downside to it. India is still not a country that can afford a device that would cost $100,000 US. Less than 0.5% of Indian population can afford that. What will you do to the remaining 99%? Again, I come back to my discussion about ECP and angiogenesis. These are patients who now have a new option for no option. Initially, they were no option patients. Offer them this new option and they will get, if not the same benefit of a transplant or an artificial heart, but at least they will have easily good qualitative improvement in their life.
Okay. So you have a clear indication of what EECP is and what patient should undergo EECP.
Yes.
So it looks like a great treatment, and your expertise in angiogenesis, what do you think this contribution of EECP would be the angiogenesis? Is there any clear evidence to show this new treatment called EECP has any effect on angiogenesis as per se?
Yes, the way EECP as a technology, the way it works is, it is external enhanced counter pulsation technology, where cuffs are applied to the lower extremity of the body, and while the heart is in a relaxation mode, the blood is pumped retrogradely upwards towards the heart. What it does is it opens up the coronary arteries and microvessels of the heart, because you are pushing blood at 1.5 times its normal pressures. So when you apply that kind of physiological pressures, you will open up microvessels. When you open up microvessels, angiogenesis will spurt open, and angiogenesis is a science of multiplication of growth factors stimulated and collateralizing and hyperperfusing that heart. So angiogenesis is a well established science. EECP in the Western world is a very well established science. Insurance companies pay for it. Unfortunately, in insurance companies in India, they have not been educated to the point to give a coding or a reimbursement protocol for EECP. That must be done in India. I encourage EECP education to the insurance sector, so that insurance policy holders can advocate to their cardiologists and to their institutions that may I have EECP. The big stumbling block at the moment is they are not able to tell their cardiologists because they are paying a very large insurance premium, but EECP is not offered to them. Once EECP is offered to that, the multiplication factor of patient enrollment for EECP in India will grow drastically, and eventual benefit with that. But the insurance company need to understand one fundamental fact. A, they are providing service to their customers, who are the premium paying customers. But B, they eventually, when a cumulative analysis will be done, they will find that they are saving money by EECP as opposed to other interventions. So it is going to be a business advantage for insurance companies to offer EECP to its customers and patients.
Oh, it's a very good point. So you seem like if EECP is reimbursed by the insurance company to the group of patients, there could be a huge saving for the insurance company as such.
Absolutely. At this moment, I speak to many Indian insurance companies, they do not understand this economics. They only know traditional therapies, well-established therapies, because EECP they think is a luxury. They do not see the value proposition associated with EECP. They think, oh, this is going to be such a lot of money we are going to spend, why should we start reimbursing? So they sidetrack the patient from going into for EECP. But once they get convinced that if a patient gets EECP, they are not only going to get well, they are going to have good quality of life, but insurance company is going to save money. Now they are going to be much more profitable than before if they would offer EECP.
So you advocate a policy decision has to be done on the government level as well as the insurance level.
Well, I think government needs to implement EECP in government and municipal hospitals all across India, because that should become part of a cardiology departmental policy. Is how can we improve our department? And one of the first steps they can take is, let us bring in a heart failure program and let us begin offering EECP. In the private sector, wonderful hospitals like Fortis, Max, Apollo, and all of them, they should also consider incorporating EECP as an integral part of cardiovascular services within every hospital. Because there will be patients within their patient pools who are not amicable to conventional therapies, but who can now be offered EECP rather than referring them to another center that offers EECP. It should be offered in-house itself.
Excellent, sir. I think you have given a very good view about interventional procedure and how a new evolving treatment should be properly positioned in the Indian market with the support of the government as well as the insurance companies. So before I close this to the viewer, I just like to ask you one question which is commonly put to any cardiologist and cardiothoracic surgeon. Why do you think India has such a huge population of cardiovascular disease, and what do you think that we should do to prevent the occurrence of cardiovascular disease in Indian population?
Yeah, I think preventive cardiology as a subspecialty within cardiology is going to be very large. I think the way for one is education of the patients in terms of prevention, like exercise, meditation, and all of those things. It will not change the genetic progression of disease in a patient who is predisposed to disease. But one of the preventive cardiology methodologies that will soon be applied in India is identification and implementation of markers in India. Markers will tell who is predisposed to a disease and who is not, and they can be prophylactically taken care of by advocating to them the right advice, the right therapeutic options for overall becoming or succumbing to a catastrophic cardiovascular patient. So I think preventive cardiology will reduce a significant burden on the government of treating heart disease by preventing heart disease.
Thank you very much, Doctor. I think it's an excellent presentation. And before we closing this interview, I just want to ask you one question. What is the value proposition of economicity of the preventive cardiology?
Yeah, I think as I mentioned, economicity and any healthcare decisions all over the world in India will play a critical role in choosing what is optimized for a population. For a population like India, preventive cardiology is going to be the strongest factor, economically speaking, as opposed to therapeutic cardiology. So prevention as opposed to therapy is a far better option even at the government level and policy decision making levels. Even cardiologists and cardiac surgeons should identify is, let us reduce the healthcare burden on the country. Let us take on social responsibility in addition to our scientific responsibility, and let us bring it down. That is where I think preventive cardiology will become the forefront of treating heart disease as opposed to all the big interventions and expensive interventions currently offered in the country.
Thank you very much, Doctor. I really thank you for providing your valuable time in coming for the interview. And we again welcome you to the World Congress of Cardiology, and we hope to look at your presentation on your angiogenesis on the meeting.
Thank you. Thank you, Dr. Ramasamy, for giving me an opportunity to reach out to the Indian population, and hopefully I have added some value in their educational process in understanding heart disease and what is going to happen in the future. All work being done all over the place by us, you part of the media, in educating the people is there are wonderful options out there. They just need to get educated about it. ECP being one of them.
Thank you, Doctor.